Hi, welcome to the Addiction Recovery Place podcast, the podcast champion addiction treatment professionals around the world. I'm your host, Chris Langley, and I'm pleased to introduce today's guest, Doug Smith from Oregon. Doug has 20 years of experience working in behavioral health services, including serving as a direct clinician, clinical director, and director of clinical development. He has a BS in psychology from Eastern Oregon University and is a certified alcohol and drug counselor level 2. Doug innovated many modern approaches to treatment services, including developing new patient-centered treatment models. He speaks nationally to professionals in the field around the positive outcomes of the emotional attachment behavioral therapy model, which he developed himself. Doug is also the recipient of the Oregon Association of Addiction Professionals 2023 Innovator of the Year Award, as well as the 2018 Addiction Professional of the Year Community Service Award. Welcome to the Addiction Recovery Place podcast, Doug. It's great to have you join us and tell our audience about the innovative work that you're doing with emotional behavioral therapy.
Thanks, Chris. It's nice to be here.
No, it's wonderful. I really appreciate your time, and thank you so much for joining me today for the podcast, Doug. So we're just going to dive straight in, shall we? So tell us about your journey and how you started emotional attachment behavioral therapy.
Great. Well, first off, Chris, before I dive in, I just want to take a second and thank you also because, I appreciate the fact I've worked in this field for 20 years in the SUD field, and the fact that you're giving a voice and an audience to professionals who work in this field is something I really appreciate. And so I want to thank you for having this forum available for professionals like myself to get on and talk a little bit about. People who work in this field, we don't do it for the money, and we typically have a ton of passion, and it's like being on the front lines of a battle zone to fight this disease on a daily basis. So I just really respect what you're doing and appreciate the efforts you're going to give a voice to the people who work in this field.
Oh, wow. I really appreciate that, Doug. Thank you so much. And I know our audience is going to love hearing about the great work that you're doing. It just sounds quite remarkable. So tell us about how you started this.
Yeah. So first off, just a little bit about my history. I grew up in a household where substance use disorder was prevalent, and my father had difficulties with alcoholism. So I know what it feels like to grow up in a household that substance use disorder is impacting. And then as I grew up, I ended up, developing and having substance use disorder myself. And so I had my own difficulties with substance use disorder. And one of the things that I found through my experience with addiction was that over the time that I was struggling with addiction, I was losing all the connections that I had in my life. Over time, I lost contact with all of my friends that I had. My whole friend group changed. I lost contact over time with my family. And ultimately I lost contact and connection, even with myself, where I was just completely disconnected from everything good in my life. It seems like as you're going, at least in my experience, as you're going through addiction, your world just keeps getting smaller and smaller and smaller. And everything that's good in your life starts to evaporate. And all it becomes about is getting drugs or alcohol and using drugs and alcohol. So that was kind of my experience walking through it. And then as I got into recovery, and I currently have 24 years clean and sober, and I have lived experience with this disease. But as I got into recovery, what I found is over time, whether it be through individual counseling, group counseling, through support groups that are out there, like 12 steps and things along those lines. I started to slowly rebuild connections in my life, right? And some of that was repairing the connections that I could, and building those back up. Don't get me wrong, there were some connections I was never able to get back, but for the ones I could repair, part of my recovery was repairing those and getting those back into an even better place than they were initially. But then also building new connections through recovery with, a lot of people I met through that process, and surrounding myself with the right type of people and people who really cared about me as an individual. So I really learned through that process how important those connections are. And when I got into the field and started counseling, one of the things I realized really quick working with clients was how important it was to build that type of a connection as a counselor with the client that you're working with. And that's typically referred to as therapeutic alliance. And it's something that all counselors learn about, but I was really passionate about what a foundational piece that was in the work that I was doing, that all the different assignments they could be doing or exercises or areas of focus were extremely important. But if I didn't have that solid connection with the client, that it wasn't going to work well. And also, being a group counselor for a lot of years, not only was it important that I had that connection with the client individually, but that there was those types of connections within the group as
Mm,
well. So as a counselor, I was always looking for ways to emotionally connect clients in processes. So if one client is sharing about something that's really impacted them and I get them talking about their feelings around it,
mm,
my mind's thinking about who else in the group has had similar things come up in their life and how can I create a connection between these two where they can relate to each other on an emotional
mm,
level. And as you do that, you start to tie these connections within the group. And what I found is the faster those connections were tied within the group and with me as a counselor, the higher the success rates were of the clients I was working with. And the research has definitely shown that to be true as well, that that therapeutic alliance that we build with clients and that clients build with their
mm,
peers is so extremely important. And in fact, that peer connection is so important that one of the most recent staffing areas that's had a huge increase over the last, 10 years is peer support.
yeah.
And so, I think people realize that it's so important to have people that aren't an authority figure like a counselor that these individuals can connect with early on to help guide them through this process. And so, thankfully, peer support has gained a lot of steam in recent
Mm,
years, and it's doing amazing work as well.
yeah.
Um, one of the things in terms of developing EABT, emotional attachment behavioral therapy, one of my big passions, after being a counselor for a lot of years and getting into clinical leadership positions, one of my big passions was innovating new models of
Mm,
care. I felt like at times, as much as I loved the substance use disorder field, I felt at times like we could be stuck in our ways as an industry, and that in some ways, people like myself with long-term recovery can make the mistake of thinking that what worked for us 20, some years
mm,
ago is going to work for the client that we're looking at
mm,
across the table today. And I think that's something that's affected us at times as an
mhm,
industry. And the reality is, over the 20 years that I've been in this career, clients are changing rapidly.
mm,
Like, the patients that we work with, the levels of acuity with mental health and other areas for
mm,
them, the levels of trauma that they're impacted with, the types of substances and how deadly those are, all of that stuff is increasing rapidly. And I have felt at times, uh, as someone working in this industry, that the clients were changing a lot faster than the staff
mm,
was, or than we were in the industry. And so I was really passionate about wanting to push some of that stuff forward. I've used things like cognitive behavioral therapy and dialectical
mm,
behavioral therapy all of my career, and I've seen the amazing good that comes from those models working with clients. But I also have seen some of the areas that I felt like I would like to see improved.
mm,
And so all of that kind of formulated into me wanting to develop this new model. And I wanted to develop something that had a three-prong effect to it.
mhm,
I feel like with CBT and DBT, one of the things they do really well is they address immediate behaviors of concern. When clients come to us that are struggling with substance use disorder, they've got some behavioral stuff going on that's really impacting their life and threatening their lives in some ways, right?
mm,
And so it's really important that we address those immediate behaviors. So I think CBT and DBT do that really well. But at times I have felt like the core issues underneath those behaviors that led to some of those behaviors developing in the first place don't get addressed as much as I would
Mm,
like to see them be addressed. And so I wanted a therapy model that not only addressed those immediate behaviors, but also addressed the core issues that were underneath those behaviors. And then the other area that at times would bother me working with clients is I would see them change their negative behaviors that they came in doing, but they wouldn't replace the negatives that they removed from their life with positives in their life. And my belief is if you take a negative out of the equation and don't replace it with a positive, you're leaving that void empty,
mm,
and eventually the negative is going to fall right back into place, And so when I talk about a therapy model with a three-prong effect, what I really was shooting for was something that, number one, addressed those immediate behavioral concerns. Number two, dealt with the core issues or started to work on those core issues underneath those behaviors. And number three, improve the quality of the relationships and the lives for these
mm,
individuals. And I don't know that EABT does it perfectly, but I feel like it's really, shown to begin to accomplish those things with the clients that we're working with. And so I'm extremely excited about it. Another area when I was developing this model, as a counselor, pretty new in the field, at times I could receive the message that when you're working with clients, don't worry about their feelings. Their feelings aren't important. It's their thoughts and their behaviors. That's where we can make the biggest change with these clients. And that always bugged me a
mm,
little bit because as somebody who had struggled with substance use disorder,
mm,
the main reasons I used was to feel and not to feel. Like those were the two primary things that made me want to use. And so I felt there was just something intuitively when I would hear that, that it's like, that doesn't make sense to me. Like I
mm,
feel like those emotions are really important. And so I wanted something that was more emotion primary. And there's a lot of similarities, just to give a shout out to emotional focus therapy, and I believe her name's Sue Johnson, who actually passed
mm,
away. Emotionally focused therapy was one of the first therapy models to really focus on that, and it also incorporated some attachment stuff.
mm,
So there's a lot I gleaned from what they were doing. I also really wanted to create a model that was self-directed and
mm,
empowering. I think one of the biggest changes I've seen in clients, especially over the last 10 years, is, so much when I first got into this field was focused on 12-step facilitation, helping people see that they're powerless and, work with them on their denial, all of those sorts of things. And what I've seen over the last 10 years is that the clients coming in to treatment don't digest the idea of powerlessness as well as they did 10 years ago. I think their trust for large
mm,
institutions has decreased a lot over the last 10 years. And I think that's not just a substance use disorder. I think that's a society type of thing
mm,
where trust for large institutions, whether it be religion or the police force or the government or whatever, there's been a huge decrease in some of those trusts of larger
mm,
institutions. And so the idea of a counselor um, immediately working with a client on them accepting powerlessness and challenging their denial. When you're working with a client that way, it's almost a top-down approach
mm,
where you're putting yourself as an authority
mm,
figure and them in a submissive role, and you're teaching them this stuff. And sometimes there's a degree of challenging that comes with it and stuff like that. And what I've seen over the last 10 years is clients' capacity to digest that and handle that while you're building a therapeutic alliance with them is decreasing rapidly. So I wanted something that was more where the client was in charge of it. It was more
mm,
self-directed, like motivational interviewing has that
yeah,
component to it. It was more empowering, where it lifted people up instead of, you know, focused on them accepting powerlessness for themselves. And so those components were extremely important to me. And then I also, being a counselor myself, I wanted to create a therapy model that was for counselors to use. And
mm,
so, there isn't there isn't a lot of theoretical stuff behind my model as much as exercises and workbooks and curriculum. Like when people purchase stuff to use this model for me, they're quite often surprised that when they open the workbook, it's just filled with exercises to do with patients. But I'm a counselor, and I created it for counselors to use with clients. And then when we rolled this out, I created this back in the end of 2020, early 2021. And when we rolled this out at the treatment center I was working at in 2021, we were really amazed how quickly patients flocked to emotional attachment behavioral therapy. They all started asking if they could be in that group. We started off opening one group, and within a short period of time, we had to open additional groups. And the other thing that we were really amazed at, I was the clinical director at that organization at that point. The other thing we were really amazed is after the first year, when we started to look at the data, it was pretty impressive how EABT compared to the other evidence-based practice models we were using with CBT and DBT and 12-step facilitation. So, yeah, so all of that is kind of how the journey of this
Wow.
began, and how when it rolled out, it was, it was a real surprise, at least to me. Maybe it's just that when I create something, I can be a little insecure about what I'm doing. So I didn't know whether it's going to work or not,
Mhm.
But when we rolled it out, it's like, whoa,
Yeah.
this is not only really
Mhm.
popular, but it's showing a lot of effectiveness. And so that was extremely exciting.
Wow. Well, firstly, congratulations. That's such a journey that you've just explained to me, and in such a short space of time, what you've achieved with this new therapy model is quite incredible, Doug. So how does this therapy work, and what's actually involved?
Yeah, to try to boil it down in a nutshell with attachment theory, what they found, I was talking earlier about
Mm,
connections,
mm,
and the founder of attachment theory is John Bowlby. He was a British psychologist back in the
mm,
1950s, and he described attachment as a lasting psychological connectedness between human
mm,
beings. So if you think about all the talk I was talking about with
mm,
connections and how important those connections are, that's exactly how he described attachment in a nutshell. And so, as a counselor who knew that connections was extremely important, attachment theory has always been something that's been near and dear to
mm,
me, and I've tried to learn more and glean more from it and do research around it. So, in terms of how this therapy model works, with attachment theory, after attachment theory was developed, they ended up discovering that people have different styles of
mm,
attachment. So there's 4 different styles of attachment, and one of them is called secure attachment, and the other 3 are all different forms of insecure attachment. Um, they were initially titled as ambivalent insecure attachment, avoidant insecure attachment, and disorganized insecure, attachment. And those 4 attachment styles is a lot of how this model
mm,
works. We simplified the names to make it easier for the clients that we're working with. So instead of ambivalent insecure, we call that one anxious attachment. Instead of avoidant insecure, we just call that one avoidant attachment. And instead of disorganized insecure, we call that one fearful
mm,
attachment. But those 4 attachment styles that were actually discovered by a lady named Mary Ainsworth in a research study that she did in the 70s called the Strange Situation Study, that's the focus with this
mm,
therapy model.
mm,
And what we ultimately do is we help people to understand their attachment styles. And with attachment styles, it's not like there's 4 of them and you fit into one. You have a little bit of all of
yeah.
these, right? And so you kind of look at where am I on the scale. And the other thing with these attachment styles is they're always fluid, right?
Mm,
So for instance, when I was hitting rock bottom in my addiction, my attachment styles were in one place. But 3 years later in recovery, my attachment styles had improved. And I had talked about those connections starting to rebuild in my recovery. That's part of what happens,
mm,
right? And so not only do we have a little bit of all 4 of these, but they're constantly fluctuating. I know people in my life who are extremely healthy, and their attachment styles are very healthy, and then something significant happens to them, like, a death for somebody close to them that they love, and it can really affect their attachment over a period of time.
mm,
So, once again, these are always fluid and stuff, but in a nutshell, with this therapy model, what we want is we want to assess your levels of attachment styles. And we want to see those 3 insecure attachment styles come down over time. And we want to see that secure attachment style increase over time.
Mhm.
And that's exactly so far what EABT has been shown to be able to do, which is extremely exciting. And the other thing that we really want with this therapy model is it really focuses on, when I talk about that therapeutic alliance or that connection between the counselor and the client, it really focuses on putting safety first. So everything that we do with this model is around creating a safe environment for the clients to do this work.
Mhm.
And so we train all of the counselors who are using this model how to create safety in their relationship with the client, and also when applicable in the group therapy process,
Mhm.
and we do that by teaching them what sort of environmental factors tend to lead toward creating secure attachment for people. And so so they create that type of an environment for the client to do the work. And then the focus of the work is, let's decrease those insecure attachment styles and increase your insecure attachment styles. And in a nutshell, that's how this therapy model
Mm.
works.
Wow. That's fascinating stuff. This is something I've not really come across in my work experience. And yeah, this makes a lot of sense to me, and I can see how this really will work with the client groups that you work with.
Just really quick too,
Mm.
Chris, just to say something. One of the top things I hear when I present this model at conferences and stuff is people saying what you just said, which is, this makes a ton of sense, and I've never seen anything
Mm.
like this before.
Yeah,
And so,
yeah,
yeah, it's exciting that we can start to work directly on some of these areas.
definitely, definitely, Doug. So, what are the client groups that you work with primarily, or what are the main client groups that you work with?
Yeah, so one of the first EABT presentations I did, Um, after the presentation was
Mm.
over, I had a counselor walk up to me and say, you presented this for substance use disorder, but why is this only related to substance use
Mhm.
disorder? Attachment theory is so foundational. It seems like this applies to a large area of issues, and so I bring that up because over the last few years, I've really started to realize, even though I created it for this,
Mm.
that it applies to a lot of different areas.
Definitely.
That being said, it's still early in the development, right? So currently the client groups that we're using it for are mostly substance use disorder. We have an adult curriculum,
Mm.
and we use it with adult populations with substance use disorder. It's showing a lot of success working with adolescents with
Mm.
substance use disorder. So that's another area that we work with. I recently have rolled out a new workbook for LGBTQ plus, which is something I'm extremely passionate about, and so that's a population that it's working with. And then I mentioned peer support earlier, and the great work peer support
Mm.
is doing. We have a peer support curriculum that's just in the final stages. I think that should be ready in the next month or so to start to roll out. There's also a parents curriculum for parents who have uh, children that are maybe in adolescent programs or stuff like that. So there's a parenting curriculum that we're working on. And then I also have couples therapists who are using this model to research how it works with couples. So, to answer your
Mm.
question, primarily what you're seeing right now, or what we're seeing, is substance use disorder
Mm.
focus, but it's already starting to branch out into these other areas. I also have therapists using this individually in different
Mm.
areas for things like trauma
Mm.
therapy and things along those
Mm.
lines. So I really feel like it's a foundational type of
Mm.
model, and it's going to be able to go in different
Mhm.
directions. But currently, substance use disorder is the main area that it's rolling
Yep.
out in.
Excellent stuff. Excellent. Thank you for explaining that to us, Doug. So what's the statistical data with EABT groups versus control groups? Can you explain the statistics around this?
Yeah. So on the when I mentioned earlier that when we rolled EABT out, it was extremely popular, and we were excited about how many patients were drawn to it. What we found is, over a 12-month period, we had a total of over 700 patients that we did a pilot study around. And some of them would choose the EABT group to go into, and some of them would choose the other evidence-based practice models, which would be CBT, DBT, 12-step facilitation, things along those lines. And what we found over that 12-month period is that the EABT patients had an 11% higher rate of completing their treatment experience than the averages of the other evidence-based practice models. So that was extremely exciting. We also found, that 13% more EABT patients transition to the next level of care than the other evidence-based practice models. So when it comes to treatment episodes, the most important things is that they stay there and that they complete their treatment and that they move on to the next level of care and that they followed through with continuing to work on this after they leave that treatment episode. And both of those things showed substantial, significance over the other evidence-based practice groups. Atypical discharges is one of the most difficult things that comes up for clients in treatment experiences. An atypical discharge is when they leave treatment early, and sometimes they call that against clinical advice or against medical advice. But that's one of the number one things that leads to not having a successful outcome for a patient, because as you can imagine, the high majority of the ones who leave treatment early end up using again. And so we were excited to see over that 12-month period that the atypical discharges with EABT were almost half as many as the other evidence-based practice models, which is just crazy. And one of the things we found working with Oregon Research Institute, who is our research partner that we're working with, is that the levels of engagement and the levels of retention with this model were very high compared to those other models. And I think a lot of it is, first off, creating that safe environment that I talked about beforehand, where, the counselor focuses on safety first on everything they do and creating an environment that's really safe. It made patients feel safe and welcomed coming into the group, and it made them want to stay in the group and not want to leave, which was great. There was actually a 15% higher length of stay with EABT than the other evidence-based practice group, because a lot of the patients wanted to extend and stay longer and do the work, which was extremely exciting. And then anyone who's in the treatment field, like I mentioned earlier, the levels of acuity with the patients that we're working with are just constantly increasing, right? So, when I first got into treatment, when I first got into the treatment field 20 years ago, we didn't talk a ton about mental health and co-occurring disorders, but now it's the norm that everybody has co-occurring disorders, and you rarely see people that don't. And one of the things that was extremely exciting through the pilot data that we looked at with EABT is, the majority of clients today coming into treatment have some form of trauma in their past, and especially coming out of the pandemic. The pandemic had so much trauma just worldwide going on for people that I personally still don't think we've fully seen the ramifications of the pandemic on things like the substance use disorder field. I think it's still kind of coming to pass to some degree, but trauma is something that is constantly impacting the clients that are coming in and working on their substance use disorder. And we've done a good job in the last 10 years of trying to become more trauma informed. And I think as mental health and substance use disorder have kind of combined forces and started working together better over the last 10 or 15 years, we've become more trauma informed on how we treat clients and stuff like that. But with EABT, what we found is that clients with a history of trauma had an 18% higher success rate with this model than they did with CBT or DBT. So that's huge. And then arguably one of the most high-risk populations in the treatment field is people that are the ages of 25 and under tend to be really high risk. And EABT showed a 21% higher success rate with people in that age group than with the other evidence-based practice models. And And like I mentioned, that's led to us doing more work with adolescents. Um, one of the organizations that I've been working with adolescents, we had after a 10-week period, we had them retake the attachment style quiz, which assesses where their attachment styles are. And all of the people in that group, their insecure attachment styles were coming down and their secure attachments were increasing. And when I got the results of it and was looking at the graph and stuff like that, it was an emotional thing
Mm.
to see those types of results, because that's exactly why I developed this model in the first place. So I'll also mention that, this is all pilot data, so there's more research to be done,
Mhm.
right? And Oregon Research Institute and myself are applying through the National Institute of Health for a larger grant to be able to do a 5-year longitudinal study. We want to work towards this being a evidence-based practice.
Mm.
So there's a lot more to study and a lot more to look at, but for initial results, those are really good. I also wanted to ask Chris, do you mind if I go back and spend just a minute talking about like what the primary objectives of
Of
EABT are,
course. Of course.
and kind of explain that for
Mm.
people? So with EABT, we have 8 primary objectives, and the first one is learning about your attachment styles. So we teach everyone who comes into this group about what the 4 attachment styles
Mm.
are, and then we have them take the attachment style quiz, which I referenced just a few minutes ago. And the attachment style quiz lets them know what their different attachment styles are and what their most prominent insecure attachment characteristics are, because those types of characteristics can impact us and our stress levels a lot on a daily basis. And The second primary objective is identifying their core attachment stressors. And what we mean by that, I was talking earlier about the 3-prong effect and wanting to work on the core issues underneath those behaviors for people. The core attachment stressors when it comes to EABT are partially your environmental
Mm.
factors that have impacted you over the course of your life. And it's also partially how those environmental factors led to unmet needs. So let's say, for instance, that I grew up in a household with an overly strict, parent in my household. That would be an environmental factor that can affect my attachment styles to some degree. And the research has shown this, that there's certain environmental factors that lead towards certain attachment styles. And so if I had an overly strict, parent, let's say, that environmental factor can lead to unmet needs for me where maybe I don't feel safe or I don't feel secure, or I don't feel supported or things like that. And so what we really work on with EABT is identifying what those environmental factors are that impacted you the most and what unmet needs correlate with those for you. And as we move forward with the ABT, we really focus on what those unmet needs are and starting to work on meeting those needs for yourself, and how to change some of that. Because what the research has shown is, for a lot of people with substance use disorder, they're using to get those unmet needs met,
Yeah.
right? And so if I don't feel connected to people, or if I don't feel safe, I can use drugs and alcohol. And people will refer to alcohol as social lubricant at times, where it's like it creates that sort of safety in social
Mm.
situations. A lot of times the reasons people are prone to using drugs and alcohol is to meet those needs, and the research has absolutely shown that those insecure attachments that people develop are strongly correlated with developing substance use disorder down the road. We also, number 3 for EABT, we focus on what your attachment stressors or triggers
Mm.
are. And we have people learn when those buttons get pushed, those old core attachment stressors get pushed for them. How does that manifest into physical, emotional, and mental symptoms of trigger activation? So we really want them to learn when those buttons get pushed and they go into a cycle, how can they identify that cycle faster when it's coming up for them? And then what new coping skills can they work on to intervene on that cycle? The way a lot of us in substance use have been coping with it is through the use of drugs and alcohol. And so We want to teach them new coping skills. And that's, that's taking components of CBT and DBT and bringing it in with this attachment lens. So even though this model is designed to have some differences to those, there's also parts of CBT and DBT that we use with this model as well. It's definitely like an amalgamation of different things. And then we want people to look at how these core attachment stressors affect how they think of themselves, how they think about other people, how they view the world, all those negative core beliefs that come from those core attachment issues. We want them to learn about those and begin to work on that. We want them to really look at how this is an intergenerational thing. And we do exercises where you look at what were your parents' attachment styles or your caregivers' attachment styles. For some of us, it may not be parents, it may be parents or grandparents or things like that really had an impact on us when we were children. But what were their attachment styles, and how does that lead to what our attachment styles are? How does it lead to our choice in partners and what their attachment styles are? So we want people to see like the wider context and how this is a secular type of thing that for them to be able to work on. And it's actually been really neat. One of the concerns I had, Chris, when I developed this model was that if we're focusing on, environmental factors from the past, that it could lead people with substance use disorder to just like blaming their parents for all their problems. And it actually hasn't worked out that way. What we've found with people is by learning how this is a cycle that's passed down from generation to generation, it actually gives them more empathy for the fact that their parents inherited this from the generation before them, and so it tends to lead to more empathy around the people in that cycle with them and more motivation to wanting to be one of the people that's breaking that cycle for the next generation, and so that part's been extremely cool. And then the last two primary objectives with the ABT, as I mentioned before, we do all this focus on insecure attachments and how they impact us in different ways, but we want to increase the levels of secure attachment as well. That's extremely important. So we do a lot of different exercises focused specifically on secure attachment and how we can increase that. And then anytime with substance use disorder, relapse prevention is an extremely important focus. And so we do a lot of relapse cycle exercises through the attachment lens and through EABT to look at your attachment relapse cycle and how to intervene on that if it comes up. So I appreciate you letting me go back and go over a couple of those.
I appreciate you explaining that to me, because that's incredibly remarkable. It really is, and I'm learning so much from this already, Doug. So thank you very much indeed. Tell us about the group training that you offer and how this is accessed.
Yeah. So what I'm doing currently, and once again, this model is still building and growing as we speak. What I'm doing currently is people that are interested in bringing this model to their organization, I provide a certification training. And so that group training is 2 days and it's 16 hours long. It's certified by NADAC. Or it's accredited by NADAC. So anywhere in the nation, I can go and provide this training and provide CEUs to all the people who participate in it. But it's 16 hours long. And in that group training, being in clinical leadership roles, I've done a lot of trainings with clinicians and people coming into the field and all sorts of stuff. And one of the main things I've learned from training experience is that the best way people learn is experiential. It's not by just listening to me for 16 hours. No one wants to listen to me for 16 hours, right?
No.
But it's like the way they're going to learn the best is by practicing some of this stuff. So I really set up the group training where there's a short introduction process where I go over what EABT is and all that for the first hour or so. But then the rest of it is the clinicians completing the exercises that the clients actually do and practicing what it feels like to do that work and present that work to somebody and pair up with other clinicians in the training and take turns presenting it to each other. So they're each getting practice on what it feels like to be in the client's shoes, and they're each getting practice on what it feels like to be the clinician walking that person through that. And then we also do group practice in the training as well. so that you're getting practice on what does it feel like when you're running a group process and somebody is presenting one of these
Hmm.
exercises. So I definitely believe doing a lot of that experiential stuff is really important to be able to learn this stuff. And the really cool thing, every training I do, I start off talking about the three primary objectives of the training, which in a nutshell is learn EABT, learn what the client experiences, and learn how to counsel somebody through it. But I always tell every training there's a bonus fourth objective that I hope that most trainings will receive. And that is by doing this 2-day training and actually working on these exercises together and doing some personal work and sharing it with your coworkers, you actually tend to see these teams get more connected and
Yeah. Hmm.
close, which is super cool, especially coming out of the pandemic.
Mm.
I think all of us, felt our teams being impacted over the course of the pandemic. So having a training that not only teaches this new model, but increases the connections between your team as well is really cool. And for people that are interested in learning more about the training, they can go to my website, which is www.learneabt.com. They also can reach out and contact me at my email address. So, yeah, and hopefully we'll include some of those links
Oh, yep.
with this.
We'll have all the links below this video. Don't worry about that. No problem at all. Doug, you were featured in the United States' largest association for addiction treatment professionals, NADAC, for their national webinar series. Can you tell our audience about this and where they can find this presentation?
Yeah, well, first off, when I got the email from
Mm.
NADAC that I'd been selected to present, it was like Christmas morning for me.
Yeah.
I think I must have acted like a little kid. I called my wife right away,
Mhm.
and I was so excited because I mean, the first year or so, a lot of my presentations, living in Oregon, I was focused on this region and going around and talking to organizations or going to conferences here in the state of Oregon, a little bit in the Northwest in
Mm.
general. Um, but that was like my first opportunity to start to take this more to a national stage, which was extremely
Mhm.
exciting. And I was so honored that an organization as prestigious as NADAC chose to have me present. And the day before, when I was meeting with them, um, and they told me how many people were signed up and how many people were attending the presentation and stuff, it was well over 1,000, and it was pretty
Mhm.
exciting. I got to say, I'm glad I was doing it over the computer and not in person, because I don't know how I would have responded to talking to that many people in one room at one time. But
Mhm.
it was kind of nice over Zoom. I could just kind of
Yep.
zone in on my presentation and forget that there was all these people watching it. But it was such an exciting
Mhm.
opportunity, and being able to talk to people all, present to people all around the nation. And then when I got done with the presentation, um, my email box just started to blow up, where all these people are reaching out to me from different
Mhm.
states. and
Mhm.
um, and it definitely was a pivotal moment in the development of this model, where it felt like it took it to the next
Mhm.
level. And that's when I decided to make, the continued development and
Yeah.
implementation of this model nationwide 100% of my focus. And the organization I was with was extremely
Mm.
supportive of
Can imagine.
supporting me in going and focusing on that. So yeah, so I left an organization I'd been with for 20 years
Mhm.
and went off on my own and started doing this, which is super exciting. And anyone who's interested in seeing that NADAC presentation, if you go to NADAC's webinar page, I think it's nadac.org/webinars or something like that.
Mhm.
But if you look up NADAC webinars online, it'll pop up, and emotional attachment behavioral therapy is on there. And that was, gosh, must have been 6 months ago or something like that. And I still am having people reach out to
Of
me
course.
every week who are watching that webinar. So yeah, it's been really exciting, and I hope to continue to present for
I'm
NADAC
sure.
moving
I'm
forward.
sure. Well, that's real recognition of the great work that you're doing, Doug, and it's very inspiring. And as I said, I'm learning so much just from this hour that we're spending together, and it's very this is so exciting for me as well to hear how things have progressed. And we've got such great people doing the work that you're doing as well. This is amazing stuff. So thank you very much indeed. Last couple of questions, Doug. For anyone looking for help for their addiction or mental health and is interested in contacting you, how can they get in touch with you?
Yeah. So, first off, if you go to my website, it's got a contact page, that you can that goes straight to my email. And so the website, once again, is www.learneabt.com. The other thing I'll mention really quick is I talk about the attachment styles and the attachment style quiz on our website. Any of you can take the attachment style quiz on the website. If you want to learn what your attachment styles are and what characteristics, would be good for you to continue to work on or whatever, yeah, go on there and try it out. It's pretty fun getting to check it out and see what your attachment style is. And then another way to contact me directly is through my email address, which the name of my organization is Innovative Realities. And so my email address is doug@innovativerealities.org. So yeah, contact me either way. And I am always open to spending time talking with people to get the word out more about this model.
Fabulous. Thank you very much indeed for that, Doug. Last question. Have you a message for anyone suffering from an addiction or mental health issue that you'd like to just say?
Yeah, that's interesting. Part of that encompasses, um, my experiences in recovery myself, and also part of it encompasses how I've seen things change over the last 20 plus years that I've been involved in this stuff. So I guess the first message I would give to people is that you're not alone. As I mentioned before, when I was towards the end of my substance use disorder and hitting rock bottom, my world was getting smaller and smaller and smaller. And the smaller your world gets, the more you feel like you're all on your own and nobody will help you, or
Mm-hmm.
nobody wants to help you, and nobody can help you or whatever. And I guess I just want people to know that you're not alone. There's a lot of people out there that can relate to what you're going
Mm-hmm.
through. And there's a lot of different opportunities for you to get help. The other thing I would mention is that, a message I would have is you're not a bad person. The number one thing I see people have difficulty with when they're trying to get into recovery is the shame that comes from everything that they went through while they were in their substance use disorder. And I definitely had a lot of shame around some of the things that I had done and in my substance use disorder. And so I think it's really important that people learn as quickly as possible that that they're not a bad person. This isn't a measurement of moral character or anything like that.
Mm-hmm.
You're a person with a disease who needs help. And I'll say this too, Chris. I don't know if you can relate, but over the course of my recovery over the last 20 years, some of the absolute best people I've ever met in my life are recovering substance use disorder individuals. There's just something about somebody who pulls themselves up from the bottom and builds their life back up
Mm-hmm.
that it takes so much fortitude, and I have so much respect for the people who accomplish that. And so, I think there's something about going through all these experiences that if you can come out the other side and start to work on it, you'll realize that you're an amazing person and you can accomplish anything you want.
Yep.
And then the last message I would give is just that there's a lot of paths to recovery. I think, and this goes to what I was talking about before, I think one of the mistakes that happens in our field at times is people will give newcomers the message that there's only one way to get out of this, and that if you want recovery, you've got to do A, B, and C. And the reality is, more and more we're realizing in this field that, first off, what is recovery? Recovery can be defined a lot of different ways for individuals. So what recovery might mean for me might be different than what recovery might mean for you. And so there's a lot of different definitions of recovery, and there's a lot of different ways to access recovery. So
Mm-hmm.
there's a lot of different tools at your disposal, and professionals that use different models and different directions. So
Mhm.
I would just encourage everybody to know that there's a lot of different paths for you.
Well, thank you very much indeed for that, Doug. And thank you for everything you're doing for people experiencing trauma and addiction. This has been a really interesting hour, and I'm sure the people listening to this have learnt an awful lot. This is something very new, and I love it. I'm a big fan, and
Thanks,
I'm
Chris.
truly honoured that you came onto the podcast today to speak to me. And thank you for everything you're doing. And maybe we can have you go on again in 6 months or a year to see how this is developing, because it seems that this is going to be going and going and going for a very long time. And I'm really excited to hear the journey. So thank you very much indeed, Doug.
Chris, do you mind if I mention one last?
Please do. Please do.
I guess the last thing I would like to mention is I take a lot of pride in the fact that, as I was developing this model, one of my biggest insecurities that came up is because I only have a bachelor's degree, but I've got 20 years of experience working on the front lines in this field. I would feel at times like I didn't have the right to innovate new things, that was for, PhDs and people with a lot more letters after their name than me. And granted, I'm partnered with a lot of those types of individuals and they do amazing work. But I guess I really would like to also just get that message out that we need more frontline
Mhm.
workers who've got years of experience knowing what it feels like to work with clients struggling with this, to innovate new things and create new things.
Mhm.
I feel like at times all of that innovation comes from people who may not have that same level of experience. And so I really hope that, if I could ever be any type of a support, if you're out there and listening to this podcast and you've got innovative ideas and you want somebody to kind of be the wind in your sails and give you some support along the process. Because I'll tell you, even though this idea is great and it's really blossomed, and I'm excited about it. It would not have happened if I didn't have the level of support
Mhm.
around me.
Mhm.
Innovative ideas, you know, crash and burn if there's not a group of people supporting them. And if I could be support for anybody out there with innovative ideas who's been a frontline worker, I would love to be a part of helping with that. So I just wanted to share that message as well.
Well, I can't think of any better way of finishing this conversation. And thank you very much indeed for your time today. I really appreciate it. And as I said, we'll love to have you back on again in the next 6 months or a year to hear where this is going, because it's really exciting stuff. So thank you very much indeed, Doug. Much appreciated.
That sounds great. Thank you, Chris.
Thank you.